All right. So Alan just told us how our advances helped us with TAVR, and then we seem to be good at just finding new things and new problems, right? And this is one of them. And the question that I should answer here is, should we screen for valve thrombosis, also known as HALT, or early hypoattenuated leaflet thickening? I think that's something that the imagers invented so that they have a role in the TAVR programs. Okay, but in all seriousness, they find it. So this is a typical picture. You saw it before, a TAVR. I think there's a screen here. Let's see. Otherwise, you see these hypoattenuated thickenings there on the CT. They can be in all leaflets. In one leaflet, seems that there's not really a rule to it. And I put this little table together. There might be more studies, but this is what I found quickly here. Just to, on the left, mention the authors. In the middle, the incidences. On the right, some factors that they put in their conclusions. And it seems that you see the highest is 23% in 78 patients. If you look at the bigger studies, Resolve and SAVR, it's like 13%. Seems to hover around a 12 to 13% percentage that you see in your population. If you don't screen for that, that's what you're going to miss, because everybody shows these 12 to 13% probably. It seems like, for whatever reason, the balloon expandable valves show more thrombosis than the self-expanding valves. Interestingly, and that I think confuses some engineers at least, is that the bigger valves actually show more of that valve thrombosis. Again, small numbers, but it seems to be quite consistent. And it seems to be associated with your treatment strategy after deployment, because some of us probably already do Coumadin for 2 or 3 months, and some might adhere to the strategy of dual antiplatelet therapy or just aspirin, because there's really also no strict guideline. But it seems to be associated with, so if you're on a Coumadin treatment strategy, you have less of that, which is almost obvious then. So again, 12%, I just took the average out of those 5. Interestingly here, Dr. Pake, I think is from Germany, the third one. They just published also an article in JACC Interventions, I believe, not too long ago. And they analyzed their data for outcomes, and they call it medium-term outcomes. I think 406 days of medium follow-up. And the good news is they didn't see any significant signal towards TIAs or strokes. So there is this valve thrombosis, but it doesn't seem to accumulate in higher risk of stroke. That's the good news, but we still have to deal with it. Again, here's a summary, and this is from that larger Lancet paper here. It seems that the balloon expandable valve here, Edwards mentioned, is slightly higher than the Evolut or Medtronic valve, 6 to 14%. But you can also see it in surgical valves. So I think that's what I would criticize our surgeons, because we, of course, did all these CTs now and actually very thorough follow-up. We don't know what it was, 5 or 10 years ago, and maybe our surgeons could comment on it. But the Magna valve showed a signal here in this study. Interesting questions. So possible mechanism, Dr. Dangas really wrote a nice review article here, and it seems to be this Virchow triad, right? So the surface factors, incomplete prosthesis, endothelialization, as some examples here, leaflet damage, and here comes, of course, the question, what if we do valve and crack these valves? Is that really long-term a good result? Because we're thinking about long-term here, right? So I don't know how you guys see it, but my patients don't want to have SAVR anymore, right? So they ask for TAVR, they will be younger and younger. So if we do all of these things, what does that really matter in 10 or 15 years if we have valve thrombosis? We shouldn't think about 5 or 8 years. We should be thinking long-term here. Hemostatic factors, no data. I mean, we just talked about it on our table yet. We have all these valve trials. Do we do any biomarker studies? No. I don't know why nobody wants to invest that to find out how phenotypes are actually playing a role in valve thrombosis in all of these outcomes. We're trying to get money. Nobody wants to give us some money. And then here, I just met Dr. Marwan in Vienna in a completely different setting. But they also wrote a little review article on the left, shear stresses. There might be some interaction with clopidogrel in certain patients. But again, we could test that, right? We could find all about it. We just have to do it instead of just implanting thousands of valves. We should start thinking and measuring things, right? So put a bug in your ear. So one of our fellows, I don't know if he's still here, Michael, he did a nice study on actually pacemakers after TAVR, and what he found that there was actually a quite significant subclinical atrial fibrillation incidence. So when you look at the pacemaker analyses down the road, and you don't rely just on your clinical assessment of EKGs or asking primary care physicians, you actually find a good number of patients with atrial fibrillation, and guess what? It's about 15%. I'm just wondering, is this just a coincidence in numbers, or is there some sort of phenotype in patients? Maybe that is part of the anticoagulation or coagulation pathway in some patients, that they have unknown AFib and it settles down there. Just put it in your ear. So there's some trials, we heard about it, so I'm not going to spend a lot of it because there was already a slide on it. The Galileo trial, at least per website, is not recruiting anymore. The popular TAVI is recruiting, that's aspirin and clopidogrel versus oral anticoagulation and clopidogrel, and Atlantis with apixaban. I think those were, I agree, interesting outcomes, and see if we can reduce HALT. And as take-home message, I would say, since it is such a high incidence and prevalence, I would say yes, you should screen for valve thrombosis, especially if you're a balloon expandable TAVR center. It seems like there's not a lot of data on that, but if you look at the Lancet paper, in a few patients, they reported that 50% of them, it was maybe just 20 patients or so, but 50% had a recurrence rate. So if you treat them, you have to have a strategy of re-imaging them, I would say, because some of them will actually have HALT again after you stop your Coumadin or whatever strategy you're using. So I think after 3 months, it's not over yet, so there's more data to come. And then there's these signals for balloon expandable, and then for whatever reason, larger valves at this point, and it seems like if you have an anticoagulation strategy, you're doing better there. I have no idea what it means long-term, but I have my suspicion that all of these little things that we're finding are what determined the early degeneration in these valves, in surgical valves and TAVR valves. And I think we need to have, when we do all of these nice trials, we should have sub-studies where we do a really advanced biomarker study as well for phenotypes, and I hope that that's going to happen soon. Thank you very much for the invitation.